Well, more and more, I get time during my day, my work day, to talk about cholesterol because people are asking me about it. And uh, more and more people want to hear about these issues, and we want to make this information available to everybody if possible. So, and in my office, I'm seeing more and more people who aren't trying to lose weight. They're not trying to reverse diabetes. They're worried about their cholesterol. And so I just want to remind everyone, if you don't have this book or don't have access to Ketogenic, The Science of Therapeutic Carbohydrate Restriction, it is the textbook I'm pretty proud of. We contributed 2 chapters, one on basic nutrition and the second one on the use of therapeutic carbohydrate restriction for obesity treatment and diabetes reversal. In the office, if you do make it to my office, I like to pull out a little show and tell, the Banting diet book from 1860-ish, which is the beginning of this approach, not the keto diet for epilepsy. You've heard me talk about that. This is not the keto diet for epilepsy. Has a different background. So the Banting diet was a diet book published in London at 1 shilling and is the basis for what I teach. And then I pull out a book from 1923, the Osler Textbook of Medicine, and point out basically that the keto diet, 10 grams of carbs per day, was used to treat diabetes in 1923, which turns out to be exactly 100 years before the first comprehensive textbook that has, I think it's a clinical and research textbook. So when you look into the year published, it's 2023. So I was, talking about that 1923 book and now the 20. It took 100 years to rediscover and to create the scientific background to support a keto diet, which had been used for humans for thousands of years. I'm getting a little ironic and a little sarcastic. After listening to Jeff Volek, who published his first paper in 2002, the same year we published our first paper, 2002, on a low-carb ketogenic diet, Jeff Volek spoke at a recent conference, the Metabolic Health Summit, which is now really the best keto science conference on earth. I think it's in its 6th or 7th year now. He spoke, and I ask every year, Professor Volek, have you learned anything that would make me stop telling my patients to not eat carbohydrates? And he said no. The more he's been studying keto, it's been over 20 years, the better it looks. And he said, no, there's no evidence that not eating carbohydrates, being in nutritional ketosis, or euketonemia, he calls it, eu meaning normal, ketoemia meaning ketone in the blood. A new term because ketosis, osis, implies abnormal condition of. And so he's even asserting that it's normal to have a certain level of ketones in your blood. Now, I've never worked directly with Professor Volek, Jeff Volek, except for once. We collaborated on a paper. Years ago, I learned that he had also approached Dr. Atkins to do research. And I said, Jeff, is there any data on low-carb diets? And actually there was. So we put together a summary. It goes way back. I think it's the Cleveland Clinic Journal of Medicine. And there were some small studies actually showing a low-carb keto diet was beneficial. This is after I had learned that a paper in 1980, 24 people wrestled together from the NIH intramural group, set out to show a keto diet was bad, low-carb diet, as it was called then, had 24 people in it, and they all lost weight, and it looked like everything got better, except the LDL cholesterol went up. And therefore, you can't do this diet. It's harmful. It'll kill you. Well, as I reflect back to that paper Jeff and I did and hear him speak 25 years later, when we went to the literature, there were no studies saying a keto diet was bad. There was no research saying a keto diet was bad. We would have found it. So this is a shift in paradigm, people's, no, not really. It's never been proven that a low-carb keto diet is bad. It's all been hearsay evidence, if you will, hearsay. And so through the years, we've been studying, publishing papers on randomized controlled trials with good follow-up, good control groups. And basically, there's a body of knowledge to actually say a low-carb diet is better than a low-fat diet, which didn't have much science behind it anyway. It actually can reverse type 2 diabetes and do all these things we're just learning about now. And it just struck me that there was never any science to say it was bad. So now when you get to the topic of cholesterol, prove to me, this is what I say in a research setting, prove to me that an LDL cholesterol is bad on a keto diet, because until you do that, I'm not worried about it. And I say this with a little bit of passion because I'm getting people coming in worried and fear-mongered and really, even fired by their doctors because they don't take the prescription medication that they've been taught to give people for an elevated cholesterol level. So just remember the context. There's no evidence in the context of a keto diet, low-carb diet, whatever you want to call it, that an elevated cholesterol is bad. I will tell you that. You come to the office, I'll tell you that. People are coming in just to be reassured. Are you sure you were referring to me? Because of the internet, you might be the exception. And so actually keep that in mind, that even though people in the power position, your physicians who have been trained in a cholesterol is bad, they might even treat cholesterol as a disease. It's not a disease. There's an old saying that to know something, you have to write it. And so now through my second iteration of a cholesterol course at the Afterlife Academy, second iteration because we, just in the last month, the team came to town, we refilmed the videos so that it's going to be much higher quality than the first one, but it's similar content. But I got to review the whole course and make updates on it. And so remember that the idea that cholesterol is bad started from rather weak science. And in a very interesting conversation with a visiting professor who came here to my office as a patient, traveling from out of town. He was a research methodologist. We started talking about cholesterol and how this all got started and all that. And I'm reminded of that you really didn't need a study to show that meningitis could be fixed by penicillin, because everyone died and one person survived. They didn't die from meningitis with penicillin or a similar antibiotic. So you didn't need a randomized controlled trial. You just had to see it happen once and then again and again and again. And maybe it didn't fix everyone at first, but you didn't need to go through funding and the research process like an FDA approval trial is done today. Then the history of medicine teaches us that James Lind, who figured out that scurvy was a problem because of lack of citrus, lack of vitamin C, he only had 12 people in his study to show that he could fix scurvy with citrus fruit. And in a book, Clinical Epidemiology by Alvin Feinstein, one of my teachers, not personally, but by book. He says it was a good thing they didn't have research methodologists to say that that wouldn't be enough people to prove anything, just 12 people, because it was enough. So if the potency of your intervention is strong, like meningitis fixing pneumonia or being fixed by penicillin, pneumonia being fixed by penicillin, you don't need large sample size, a lot of research behind it, because it works where nothing worked before. So then I'm acutely aware that if you're going to look at 40% versus 20% in an outcome study, because this was the smoking cessation rate we were studying, and I wrote studies for funding, and we needed 160 people, 80 in each group, to show the difference between 40% and 20% in a randomized trial. And it really doesn't matter what the outcome is. It's just the absolute risk to see that kind of difference, which is really big. We needed 160 people. So the smaller the difference you're trying to find, the larger number of people you need in a study. This is just basic research methodology. So the weaker your intervention is, the more people you need to be able to show a difference there. Now, back when I was in research training, the clotbuster drugs were coming out, and streptokinase was used to open up the arteries in the heart. And you would get an IV, and then tissue plasminogen activator was discovered, TPA, and they needed 40,000 people in a study in two groups, so 20,000 per group, to show a difference between 8% and 7% outcomes. I think it was mortality, so life and death, but that's a 1% absolute risk reduction. And that's why they needed 40,000 people in the clinical trial. And so I'm talking to this professor about research methodology. That was his gig. And he looked at me and said, why bother? Why bother do a study that's that big to show such a small difference? Well, first of all, it costs a lot of money, but it was funded by the company that had the drug that lowered that outcome rate by 1%. And it went, the drug started to be used in clinical practice. In a recent review or reacts video that I did that will be out very shortly, the idea of nutraceuticals and vitamins and all that came out in the 90s, late 80s and 90s. And the young reviewer of this basically kind of remarked, that was an era where there was a lot of money. There was a lot of interest in health at all cost, or at any cost. And it occurred when the vitamins started getting pushed, and there's not any FDA regulation of that. But what the light bulb went off in my mind that was the same era when the statin drugs were being developed, or when that clotbuster drug was being developed. And so it was an era where there was relative affluence. Again, who's going to pay for a study to show a difference between 8% and 7% other than the company that's going to be marketing that drug? So now let's talk, what does this have to do with cholesterol? Well, for primary prevention, meaning you don't have heart disease yet, you don't have clinical evidence of heart disease or a stroke or anything, it took 20,000 people in clinical trials to show a benefit of a statin drug. It doesn't even matter how big that relative risk reduction was, because it was small. Because you needed 20,000 people, that means the effect size, the potency of the intervention is going to be very, very small. But they needed to be able to show that difference, so they enrolled all of these people. With secondary prevention, the statin medicines, or really any cholesterol-reducing medicine for that matter, lowers the rate, the absolute rate, to a greater degree. And this is where I'm, kind of in the old paradigm and the new paradigm. If you have existing heart disease or stroke, the risk reduction, absolute risk reduction from a statin medicine might be worth doing. It only took 4,000 people in the clinical trials to show a significant difference. Much different than the 180 people needed in a smoking cessation trial, looking at 20% and 40% relative risk reduction. But so you're getting the idea that these are small effects. And it really took a visiting professor of statistical methodology to kind of say, why bother with those drugs? Why even do those studies? Because the effect was so small. Well, it came during an era where the fear about LDL cholesterol was high, and the money available to do these studies from the companies and then by government sources and was available. So Gary Taubes' book, Good Calories, Bad Calories, tells the story of how these clinical trials were not really ever very convincing about fat in the food, saturated fat in the food, cholesterol in the food, even the treatment of LDL cholesterol, that these were very small effects if there were effects. But the effects were greater for those with secondary prevention, those who've already had a problem, and now you're preventing the recurrence of it. So how does this all play out today? Cholesterol is not a disease. So please repeat after me. Cholesterol is not a disease. Thank you. I have to conduct our virtual choir here. And yeah, if anyone knows how to do that, let me know. I've always thought it would be great to have 10,000 people on a Zoom, much like those virtual choirs that you hear. But so cholesterol is not a disease. The disease we're trying to prevent is atherosclerosis. Atherosclerosis is a disease of the arteries. Interestingly, not the veins. A little trivia there. Unless you put the veins around the heart or as a bypass, or you're using a vein as an arterial bypass, the veins actually become more like arteries, and you can get atherosclerosis in the veins, but only if they're in the arterial side of the circulation. Maybe it's the pressure, maybe it's the factors that are going around. Nobody really knows, but that's why you can get blockages of bypass grafts even after coronary artery bypass surgery. But so what you want to know is your status of atherosclerosis. So I've been trying to make the language easier to understand. You want to assess the pipes. These are, we joke, we non-interventional doctors joke that really our colleagues just look at pipes. So the GI doctors look inside. The esophagus is just a pipe. Colon is just a pipe. It is, but we kind of want to make it easy for you to understand. The arteries in the body are really just pipes. Yes, they're living. They should be elastic, like a hose when it's fresh, not calcified like a garden hose that you forget to put in the house when it freezes. Not that I've ever done that, but you want to have an elastic pipe, the arteries. And you don't want to have buildup in the walls. It starts in the wall of atherosclerosis. So atherosclerosis is the problem we're trying to fix. The problem is it's hard to assess the pipes. So it's under wait a second. How could we do that? Just about every woman who's been pregnant in the last few decades, even more, has had an ultrasound. An ultrasound's done for assessing the uterus, the growing baby, the fetus. And so you can actually get ultrasounds of the neck artery, the aortic artery, the abdominal artery, and you can't do an ultrasound of the coronary artery. Those are too small. The resolution isn't good enough, but you can actually assess the squeeze of the heart. So what I recommend first to assess your pipes. So first, ask your doctor, do I have atherosclerosis? And if the doctor goes to the blood tests, these are at best predictors. They don't really tell you if you have atherosclerosis. So you want to ask the doctor, do I have it? And can we assess for it? Typically, doctors aren't into that, the prevention thing. They wait for the manifestation of a problem and then typically give medication for the result or the problem. And it's rare in my area that someone has ever asked about the food that they consume by a traditionally trained doctor. And that's sad. Food is my secret weapon. But so ask the doctor, can we assess whether I have the problem? If they say no, you go out and get this ultrasound screening. The company that I'm aware of in my area, please let me know if there are other ones, it's called Lifeline Screening. They come around and set up shop, their ultrasound machines, and you go in, you can ask for these pipes to be assessed. They'll send you a report. And if it says you have no atherosclerosis, that's good information to know. If it says you have mild or moderate or severe, that's good information to know. So I start with the ultrasound technique of checking the arteries. If someone is really concerned about their coronary artery system, these ultrasounds don't assess that. And while there might be a strong correlation between the two, there are exceptions where the heart is affected while the other arteries are not. And so some people now are going to get a test called a coronary artery calcium score, or CAC score, CAC score. You have to know the background of this study. It's been around a while, but the popularization was because a wealthy man had a calcium score, and the focus of where the calcium was right at the beginning of the two arteries that come off. It's called the left main. The main artery goes into these two left branches. He didn't have any symptoms at all. He went, got the score. They said, you have calcium at your left main. So it's not just the score, it's where the calcium is. And so he went for further evaluation and had a blockage there. It's called the widowmaker, because if you have a total blockage there, the heart basically stops because all the blood to the big side, the left ventricle, stops. No oxygen can get there. So he had procedure done. Basically, he felt it saved his life, which seemingly did. And so he said, I want to popularize the idea of people getting this score. Wrote a movie called The Widowmaker and asked some people to popularize the coronary artery calcium score. So meanwhile, Dr. Agatston in Miami is doing a lot of these scores. In fact, the little name on the calcium score is called the Agatston score for Dr. Agatston. And he's publishing papers, and the mainstream cardiologists don't know what to do with this guy. I mean, they're basically putting in a new test that unfortunately tells you a lot and tells you nothing. So it depends what your score is. In other words, it's a very sensitive test, meaning if it's 0, it means you don't have the problem. But if it's not 0, it's not very specific, meaning if it's not 0, it doesn't tell you if you have the disease or not. So looking at the coronary arteries, the coronary artery calcium score, if it's 0, really means you have no calcified plaque in the coronary arteries. And in large studies looking over a period of years, your risk for a heart attack is very low. Now, it's not 0. It's not a perfect test, but it gives you a risk stratification that your coronary artery calcium score is really low and your risk for a heart attack is really low. So what does that mean? Well, in a recent conversation with someone who came to me, I sleuthed out this paper, The Role of Coronary Artery Calcium Score in Primary Prevention of Cardiovascular Disease. Now, remember that primary prevention is that you don't have any clinical heart attack or stroke yet. Most people are in this category. So primary prevention, if your doctor for primary prevention wants to be on a medication to treat cholesterol, which is not a disease, but a predictor, remember the number of people that had to be in studies to show the change for the primary prevention was a lot of people, meaning the effect was really low. They argue here in this paper that if your coronary score is 0, it doesn't matter what your cholesterol is. You don't need treatment for statins, treatment for cholesterol with statins or other kind of cholesterol medicine. So this is kind of a chink in the armor of everyone needs statins, or it could be a loophole, if you will, or, if the doctor says everyone needs it, well, actually, there are other well-respected doctors who don't feel that way, and who don't, remember, do you have the disease? atherosclerosis or just a high cholesterol. That's a big difference. And I'll save you the trip to my office. We don't have to have this discussion. If you've never had a clinical event and your cholesterol is high, you get a coronary score. If your coronary score is not 0, well, we're in a bit of a pickle because you might have narrowing. So remember, so even like if the coronary score is 1 or 5 or 50, it's very, very low. It can go up to 1,000 or higher, but it could mean that you have narrowing at that place. So the coronary calcium score is a bit of a Pandora's box, meaning you open this and you let out all of this non-specific information. And so someone came to me recently and said, I really want to know. I really want to know the anatomy of my coronary arteries. There is a second test you can do called a coronary CT angiogram. So the first coronary artery score does use a CT scan, but there's no dye injected and it can't see the inside of the arteries. But a CT coronary angiogram, coronary CT, CCTA is the acronym. You go in that same CT scanner, but they inject dye into your vein. It lights up the arteries, and you can actually get a scan that shows you the inside of your coronary arteries. It was pretty amazing, actually. But, we can see things a little far away. But if someone on the moon, you would think we'd be able to visualize these arteries that are just right so close. It's hard because the heart is a moving object. You have to get all that, separate all that out. But the CT angiogram, it would be the next step to see non-invasively, meaning it's not a heart catheterization. Oh, that's the next level. So if you have chest pain or tightness or up the arm or up the jaw, typically the left side, but even atypical heart pain could be all the way through to the back. The hallmark of it is that it's during exertion, that exertional chest pain or tightness, it's really not pain, it's tightness, is something we take very seriously as physicians. So if you came to the ER complaining of that, if it looked like you might be having a heart attack, the gold standard to look at the coronary arteries is to take you to the catheterization lab or cath lab, put a tube in the artery through the leg or the arm, and actually inject dye directly into that left main coronary artery, take X-ray pictures. And so it's invasive, meaning you have a tube put in there, but it's done all the time. Pretty amazing that it's so simple, but it's not risk-free. And it's much more expensive because you have to mobilize other humans to be there in the lab, and you're injecting dye. And so that's the gold standard to see if you have narrowing inside your coronary arteries, the heart catheterization. Now, it's pretty unusual for someone to have that level of testing if you have no symptoms. But there are some circumstances where you might get a functional test called a treadmill test or a stress test. This is where you get on a treadmill, they make it go faster and faster, they raise the incline, they have a heart monitor, or they might even use some injectable dye into the heart, and then they see if your heart gets enough blood flow during exercise. That's called a functional test. So a functional test will tell you if you have sufficient flow to a good degree. It's not perfect. An anatomic test, like the coronary CT angiogram, tells you the anatomy, but it doesn't tell you the function. So even when I was in training, I did some time in the cardiology unit, the coronary care unit. There's always a trade-off between knowing the anatomy, whether there's a blockage, and then knowing the function, whether the heart is getting enough blood, even if there's a blockage. And you want to know that because there may be a blockage, but it might not be limiting the flow. So you don't want to put in a foreign body called a stent or some other sort of invasive thing or even a bypass graft if it's not limiting the flow. But if you wait till you have a heart attack to figure out that there's flow being limited, you might have lost part of your heart function. So this is kind of the reason why this is not so clear cut on what to do. So the discussion I had recently, it was someone who wanted, so the coronary artery calcium score was 1,000. No, excuse me, 500. It was somewhere in there, 500 to 1,000. It was high. I mean, in studies, it means there is arterial damage. There is some calcification, which is a sign of healing, actually. Calcified lesion is a sign of healing. It's not a sign that necessarily that there's something bad. And that's hard for people to grasp. The calcium score might go up, but it doesn't mean there's more narrowing happening. Again, that's kind of confusing. But so you really kind of pressed the issue. I don't do this all the time. Please don't, swamp me with requests for these scans because they're not easy to get. But he found an area where he could, out of pocket, pay for the CT coronary angiogram, the more invasive one. The cardiologist in my area didn't really want to do it. It was going to be a couple $1,000s out of pocket. He found a place where it was cheaper than that. The scan is done, and most of the arteries are actually clear, even though the calcium score was really high. And there was one little place with about a 50% blockage, which is not typically flow limiting the blood flow there. And I say, clearly because that's the name of the company that does the CLEERLY, that does the assessment of the scan. So you get the results by this company. I think it was something like $800. So, with travel and all that, it's going to be $1,000 to get that information. And even then, we were left with, well, there is a little blockage there. What does it mean? So I sent him back to the cardiologist. I don't know the result yet. If it were me and I was really concerned, I'd get on a treadmill with monitoring and I'd check the heart to see how far I could go. Or what I do is ask, well, how much exercise are you doing? How much exertion are you doing? Are you able to do what you want to do without any problem? And the reason for that, I ask, this is personalizing it to that person, is that you may have blockages. But if you don't do a whole lot of, you're not running marathons, you're not climbing up 10 flights of stairs every day, you're not at the gym doing all this stuff, you may not need perfect blood flow going to all of your heart all the time. And so if your adaptive response, your heart is made to what you do, it allows you to live normally. You don't want to just go in and assess your arteries willy-nilly because the interventions can cause problems. I mean, so you go in, there's a blockage, you put a stent in there, which is like a Chinese finger torture thing. You open it up and it keeps the artery open, but these stents block over time. You can go in and revascularize, put arteries around veins that become arteries, but then those block over time. So there's, I think, this other discussion I had, someone came and kind of asked my judgment whether he should go from the coronary score to the CT angiogram or further testing. And after discussion, learning about someone the best I can in an hour, basically decided that he didn't really need the assessment. His metaphor was, well, it's kind of like I'm driving my car. It runs just fine under the conditions I'm running it. I don't need to go in and make sure that the pipes are fine in my car. Why would I want to do that for my heart? Which was a great way to kind of make a metaphor of, you may have blockages, but you're going to live your life fine and never have a problem, perhaps. So sometimes getting that information, making an intervention might not be the right thing to do all the time. It's rare or uncommon, but sometimes with a heart catheterization or intervention, you might have a stroke or bleeding at where they do the test. So these aren't totally benign sorts of things. But so I guess I've gone from If you want to talk about blood cholesterol, we're going to talk about the old way, total cholesterol and LDL, and the new way, triglyceride and HDL. And there are several chapters in here. Ketogenic textbook came out last fall, 2023, that talk about the shift in looking at the blood cholesterol markers. It's called metabolic syndrome. High triglyceride and low HDL in the blood are what we want to target. We don't worry about the total in LDL cholesterol. And that, if you want to look at the blood, if you want to talk about your risk over time, you can plug in your numbers to the Mayo Clinic Statin Decision Aid tool or the cardiovascular risk assessment tools online. Get a risk at baseline and then see what your risk would be if you are treated with a drug. I did that recently for someone in the office, looked at it, and the change was from 2% to 1%, that there would be a problem over 10 years. And the person looked at that and said, that's nothing. I'm not worried. I'm not worried about that. So you can actually personalize that. Of course, the assumption is that that data from that database is reflective of what would happen if you're not a carb eater. These studies have been done and the prediction models are done on people who eat carbohydrates. My hunch is that we'll do even better, but that's a hunch based on all of these other things. It's not based on prospective clinical trials. I'd love to do an outcome study comparing different diets, including a keto diet. Hasn't been done yet. I don't even think it's being envisioned yet. So if you want to assess your pipes, you might get an ultrasound, coronary artery calcium score, CT angiograms, more expensive, more invasive, but not as invasive as a heart catheterization to look at the coronary arteries. This is all too much. You're welcome to come to Durham, North Carolina, or to any keto-friendly physician to discuss it. The company that I'm watching and very supportive of is Dr. Tro. Dr. Tro online is doing telemedicine and has the company just himself. He's hiring doctors to be able to do this work all over the country. Of course, Virta Health, with the big corporate structure behind it, has a much higher, more complicated intervention. I don't think they would just talk to you about cholesterol, which Dr. Tro probably would. The Virta Health intervention is they send you a kit with a Bluetooth scale, a keto monitor, ketone blood monitor, and you talk to the doctor to get off the medicine through your app. Great. The best study on diabetes reversal with a keto diet is done by the Virta Health company. And now my latest read on it is that they're kind of getting pilot studies and infiltrating the insurance system, reversing diabetes. And I've had a few people actually be in the Virta model, paying or getting it paid for, and then they come through my office. My technique is very different, much less intensive, so simpler. Perhaps one might say easier, but they both use keto methods, a keto diet. That's why it's so effective at reversing type 2 diabetes. So another paper I just wanted to highlight was a sub-study or reanalysis of a Stanford study. Lucia Aronica did the first author, a sub-study looking at the people who were in the most extremes in something called the Diet Fits study. And so they took people who did what would be kind of like an Atkins high-fat, low-carb versus a ultra-low-fat or Ornish type diet within the same study. Some people went to that extreme and stayed with it. And she compared the changes in insulin resistance and blood cholesterol. This is a paper in the journal Frontiers in Nutrition, July 2023. So it was published last year. But basically, the upshot is that they both worked and they both lowered insulin resistance. If there was any stronger change, it was with the people who were doing the low-carb diet versus the low-fat diet. But the brilliant message is they both worked. And the commonality may be that there was no junk food, no highly processed sugary foods, or some other mechanism yet unknown. So to me, the type of diet you do is less important than the metabolic outcome that you get. And so while some people peg me as just a keto guy, you'll be surprised perhaps, End Your Carb Confusion, the book that came out almost 2 years ago now, actually has 3 levels of carbs, and it's not always a keto level of carb restriction. Now, if you want to lose fat weight, want to reverse type 2 diabetes, I will always say use the strictest version. Remember, it's total carbs, not net. And people get tripped up on that, even if I'm just repeating that. New products come out and people are kind of duped by the marketing of net carbs. I always look at total carbs. It doesn't take much extra time to look at the nutrition facts on there. But a really important study saying that maybe everyone's been right all along, that an extreme low carb diet, an extreme low fat diet, if you do it and you do it properly, actually has reduction in insulin resistance. Both do. Now, I wanted to also highlight some other research one was a research presentation. If you've been following Dave Feldman and the Cholesterol Code and this group of people who have super high LDL cholesterols on a low carb diet, many of them are lean and have high HDLs at the same time and low triglycerides. So they basically have the metabolic syndrome fixed, but the LDL is really high. The initial study being done is enrolling 100 people who say they've been on a low-carb keto diet, doing a scan, that coronary CT angiogram, so that people are actually being flown to one of the best centers in the world for that particular study, that test. And they're all getting the same scanner. So it's great design. And they presented the baseline data from these 100 people. They actually had 80, for some reason, 80 presented in this presentation. And the remarkable thing on that, they average 4.5 years of self-reported keto diet. 40 of the 80 people had no evidence of any sort of blockage in the CT angiogram, coronary, the CCTA. We're not talking calcium score here. It's the more invasive one. So if the LDL story started with a little girl who by the age of 5 had a heart attack, had a problem, the familial hyperlipidemia with super high LDLs in the 700, 800 level, caused problems over just a matter of a few years. So here, if LDL is the problem and not some other issue with that familial hyperlipidemia, that's sort of the other hypothesis. It has something to do with clotting, with platelets, something like that, not the LDL. If that LDL is a problem, then everyone should have had disease if it's a problem in everyone. So at best, or no, at least there's a subgroup of people who on average 4 to 5 years following a keto diet had no blockage at all. The half that had some blockage didn't have much, and it was comparable to those in a comparative group in Miami who had no heart disease at all, a healthy group. So compared to typical Americans, which of course is not a great comparison, but there wasn't any more blockage than a group that had low LDLs and didn't have any heart disease. In that study, it's pretty awesome. You can see the presentation online, or you could go to my YouTube channel and see my review of it if you want. I created a few figures and talked in detail about the money figure, which shows someone had an LDL almost 600. So if your doctor is, freaking you out and fear mongering you because your LDL is 150, you want it under 100 or you want it as low as possible. Some doctors say these people had average LDLs in the 300s, and someone had a LDL of 600 almost. So super high. So the baseline presentation was made. Matt Budoff, Budoff, LMHR. Matt Budoff's the principal investigator who does the scans LMHR means lean mass hyperresponder, and it will come up on your YouTube, and you can watch the presentation. The questions were pretty fascinating too, if you get to that part, because it's the paradigm clash that, the old and the new and the, or maybe like the Aronica study, maybe they're all right. Maybe both sides are right for different reasons. But so that's a great contribution out there. Now the study is not done. They're following people now for a year with documentation that they're in ketosis, with documentation of the labs. And so the full study is taking people for a year and repeating that coronary CT angiogram to see if there's any change. And we should have those results, next December or a year from now. Although the politics of it are fascinating. And, there are a lot of views on that one, and a lot of kind of it can't be, all the bias and all that. No, the methodology is really, really good on this one. So at least it may show a subset of people who don't have to worry about LDL. At most, it starts to kind of whittle away the idea that LDL matters at all. So if this is repeated, if other people kind of wake up to the idea that it took 20,000 people in a clinical trial to show a difference in a statin treatment, why bother, as that methodologist said in his words. While a company made a lot of money, Lipitor being one of the most profitable and sold drugs of all time, a statin medication. So there's going to be a lot of politics and rending of clothes, throwing ashes on themselves. No, it's just data. But so don't freak out if your LDL goes up to 150 or 200, or even, if all the other factors are there, your HDL's high, you're meaning, over 60 or 80. I had someone recently told me their HDL was 120. Now you might actually have a doctor start saying your HDL is too high. No, it can't be too high. They just haven't seen it that high. In this context, it can't be too high. So the LDL story evolves. I got into this deep dive by doing this cholesterol course for Adaptive Life Academy, and with the retooling of the video. Actually, you can go and take that course now as an evergreen, and the content is very similar to the new version, which is refilming. The refilming probably won't be out for, 6 or 8 months, depending on the editing in the queue for the Academy. But fascinating to see that evolve. I was trained in the LDL paradigm, that it was bad, and I'm coming out of that paradigm, at least saying that we're finding a different way to go about it. And so don't let anyone fearmonger you. Don't treat cholesterol as a disease. Atherosclerosis is the disease. Finally, I wanted to talk about Nick Norwitz. If you don't follow Nick Norwitz yet, please do. The early following and the videos he does are great. I mean, they might be a little geeky, but if you're following this, you're in that geeky realm. But Nick is a medical student at Harvard, and Nick Norwitz, Norwitz. You go to his YouTube channel, watch his first video about his story, or you might have to go to his website. I don't remember, but watch the video about his story. He had such severe ulcerative colitis as a young man that nobody knew what was going on, that he wasn't a doctor, wasn't in medical school perhaps, but he had to figure out on his own that a low-carb keto diet could fix his ulcerative colitis. And so he was really ill. And it shows it in that video, and pulls out quotes that are pretty profound. Food being an amazing tool if you use good food, and then also the barrier that you face can actually become an advantage because you've overcome that barrier. It's kind of how he ends the messaging. But he did a recent study. He calls it the Oreo study. And it was basically eating a roll of Oreos every day on top of his diet and comparing the statin LDL reduction to the LDL reduction he got eating Oreos. And meticulously done, 2 weeks of adding Oreos to his diet, his LDL plummets. The LDL goes down by adding 100 grams of carbs in the form of cookies. So, and then it goes out about twice as much as a statin drug without the Oreos, all other things being equal. It's a short-term study. He openly says that I just did this to get attention, that the mere fact that you can lower an LDL cholesterol doesn't mean the food that you're eating is good. And so he's got a lot of views, a lot of people commenting on it. And the basic idea is that just looking at an LDL without the context, what else are you doing, is really irrelevant. And showing his result. I mean, he knew that was going to happen. I mean, knowing Dave Feldman, Dave has done his own research where you can eat tons of fat and it lowers your LDL. So if you need to lower your cholesterol reading for an insurance exam, for example, an insurance test, he has a protocol where you eat a lot of fat 5 days before you get the test and your LDL plummets. Dr. Tro Kalayjian, and Nick and a collaborative group show that you could add back carbs to someone on a keto diet who has high LDL, and the LDL will come down. Some people straddle the old paradigm and the new paradigm, even doctors, and say, well, if your LDL is up on a keto diet, we'll add back some carbs and lower the LDL. Just add some back. I'm not sure that's necessary. I want proof that is harmful. The data coming from Jeff Volek and other scientists on keto diets say it's not harmful. Everyone goes into ketosis, every human and mammal for that matter, if you don't eat for 2 days. And I just want to end on that. The note that what kind of system would be designed to go into self-destruct mode or a toxic mode if there was no food around? It's as silly as one day I looked at my phone and the phone said low energy, battery is low. Should I go into self-destruct mode? Well, that's what I saw on the phone, because everyone says ketosis is bad, it's bad for you, you got to stay out of it. One of the prominent videos now on YouTube you pull up are these doctors kind of clucking like hens that ketosis is terrible, it's so bad for you. No, the phone said, should I go into safe mode? Energy is low, should I go into safe mode, not toxic self-destruct mode? So what organism would have survived through evolutionary pressure, through famine and it's only recently where we've had food availability. So ketosis is, if anything, is a protective thing. And it's anti-inflammatory. You're getting the anti-inflammatory effects of not eating the inflammatory foods as well. And yet now euketonemia is the term that Professor Volek uses. It's normal to have certain levels of ketone in the blood if you're doing a keto diet. And to those who call out keto diets as being harmful and all that, you're going to be happy that you can go into ketosis if, God forbid, you can't eat for 2 days. So actually, it's a normal thing. We store fat on our bodies. You start burning the fat on your body if you don't eat food for a couple of days, or if you don't eat carbs for a couple of days. Your body looks around and says, I have plenty of energy here. It's just fat energy. So you're starting to burn it. So I can't imagine with that behind the evolution, the lack of evidence against LDL and cholesterol, and the number of people that had to be in clinical trials for the medication treatment of cholesterol. I'm putting my eggs in the pun intended, eggs in the basket of not eating that terrible bad food, and that this is going to be an approach that is going to be healthy. The LDL goes up because it's good for you, not because it's bad for you and you need to worry about it. It's different context, yes. Doctors aren't used to it. It's not what they've seen. But please take all of these things into account and the proof should be on the people pushing the drugs to say that someone eating this way needs the medicine. A recent discussion, person came in and said, it's like my doctor's a salesman for the drug companies. They're always pushing the different drugs. I never thought of it that way, but that's how we train doctors today. It's with medication. So I hope that's helpful to reassure or maybe even to cause you to get some testing done. And the one conversation recently, the parents or the father had a heart attack at age, late 40s, and the son was getting near that age. So he was starting to worry. And so he got a calcium score. It was 0. And yes, his cholesterol's up a little bit, but not like a lean mass hyperresponder. And after some discussion, he's going to get the lifeline screening, get some more information about the arteries, and then repeat the test as he gets closer to that, eventful year that his father had a heart attack. But then I asked, well, what did your father eat? Well, it was the typical American diet. So, but even with that, regardless of what diet someone followed, if diet has something to do with the heart disease of your sibling or your relative, then you don't want to eat the way they ate if diet is related. Well, it turns out that the father smoked, which we know is one of the highest causative or risk factors for heart disease, that he didn't have diabetes, but that's the other big one. Treating obesity, treating high blood pressure, don't forget all those. Those are really the main risk factors for heart disease, not the total and LDL cholesterol. That's kind of the old paradigm view. Well, let me see. I had a few questions emailed in, and let's see. Let me see if I can. Okay, let's see. Susan says, ketogenic textbook has been helpful. Thanks for your cholesterol talks. I was on a combination of a statin and an anticoagulant for AFib. The addition of a keto diet caused some nasty bruising and nosebleeds last winter. Stopped the statin and the excessive bleeding stopped. Interesting. I was thinking more antiplatelet effect, perhaps, of a keto diet. The Inuit, when they were studied, that was one of the things that would happen in this population that didn't eat many carbs, but they would have some would have nosebleeds, and they apparently didn't have much cancer at the time. This is before the introduction of Western foods. So my docs are now pushing expensive cholesterol injections. Calcium score was 0. Carotid ultrasound was not significant. Seems crazy for something that is not a disease. Yeah, that's the way they're trained. So, and just kind of an aside for AFib, you'd want to do the traditional treatments. I don't know that a keto diet has any special advantage for that. You'd want to stay on whatever anticoagulant or anticoagulant your doctor recommended. But I wonder if you go back and just say, prove to me you have the disease, I wonder what they would say. And I had a recent meeting, someone came up to me out of the blue and said, last year you told me to go tell my doctor I was doing a Mediterranean diet, and I did that, and the emotional response was entirely different. So remember, the concern about keto is entirely emotion. It's not scientific. So if you just, say you're doing a Mediterranean diet, your doctor's going to be happy. Okay, there's the Dr. Tro website. Thank you. Thanks, Marianne. So a couple questions. The see. Oh dear. Where was it sent? If anyone has other questions, please put them there now. I'll find it in just a moment. Okay, here we go. Adrian asks, is a high CAC score reversible with page 4 and exercise? I've never seen it. I don't do a whole lot of calcium score tests. Other doctors that use a lot of calcium score tests tell me it's fairly typical to have 10% increase every year, and they don't see reversal much until I saw Dr. Ovadia, who's a cardiothoracic surgeon at a recent meeting, said that he reverses calcium score, coronary calcium score. So I went up and asked him that, for some more detail, and encouraged him to present all of those data. Well, he came up with an anecdote of someone going from something like, 400 to 380 on the calcium score. And I'm thinking, is that really different? Is that really, the test-retest reliability of these scores, there must be some variability if you got it done twice. If anyone's had it done twice and had similar or different scores, close together, within a month or two, let me know, because that information is not out there. So, no, I don't know that you can reverse a calcium score. But remember, calcium score going up could be a sign of healing, not necessarily a sign of narrowing. And that's a hard concept, I know. Adrian also asked, should particle LDL be checked in ApoEs and all that? Well, you can see my point of view now is not to worry so much about the blood, or if you do, look at triglyceride and HDL. And instead, don't worry about the blood, get the arteries checked themselves. That's what the disease is. Let's see. Liz says, I have diverticulitis and get constipated when I eat very low carb. Well, so most people eating low carb go to the bathroom less often. That's not constipation. Constipation is if you have hard stools or hard to pass stools. And there's a brilliant video from an Australian physical therapist called Moo to Poo. I know, kind of funny. It's a sticky name for a video. I highlight that. Watch it if you have any trouble passing bowel movement, or even if you want just good, proper stool hygiene. It starts with the idea that most humans squat to take a poop. So that's the squatty potty, raising the feet, taking deep breaths and all, and having proper relaxation for urination and straining for if you need to, and how to do it from inside, meaning vocalizing something like a cow would, mooing, and you want to just let your family know that's what you're doing. If you don't live alone, had stories of people coming back. But anyway, that's a great video on constipation and all of the things you can do aside from just taking stuff. So the doctor wants you to take Benefiber. Well, so Benefiber has some carbs in it, even though they might be fiber carbs, often those are absorbed. So if you're knocked out of ketosis or things aren't working the way they should, consider that maybe taking something like Benefiber or Metamucil is causing a problem. That's why I prefer milk of magnesia as a remedy rather than a fiber supplement. And then you don't have to worry about the added carbs in the fiber supplement. However, some people don't like the taste of milk of magnesia. And for that, I recommend that you pinch your nose, swallow it, drink some, something to cleanse your palate, and then the taste really is almost gone. So taste is 80 or 90% smell. If you have a cold or you pinch your nose, you're not letting that milk of mag smell go up there. You're swallowing it. So try pinching your nose. Otherwise, a magnesium supplement like Slow Mag, I think, is the one that Steve Finney recommends. Slow Mag or some other magnesium supplement like that. Some magnesium supplements work, some don't. Some people tell me they see the full pill in their stool. and that means it doesn't get absorbed to help you or broken down. So it doesn't matter how often you go, but if you have hard stools or hard to pass stools, that's not good. Magnesium helps. Adding electrolytes like sodium can help. Remember, if you're not eating carbs and you don't have high blood pressure or heart failure or kidney failure, you want to add salt. Bouillon is one way to get salt, a measured amount, so you're not, doing an unmeasured amount. Another very popular electrolyte supplement that's out there is called Element, LMNT. I am not an affiliate for it. I don't get any money for it. It's kind of expensive. That's why I'd like to recommend Bouillon first. But the Element products have different tastes and flavors, and even some keto chefs are using it to flavor their puddings. And anyway, so don't fear the salt, and you may need to add in salt if you have fatigue, if you have fatigue when you exercise, if you get dizzy or when you stand, weak or dizzy when you stand, they can add in salt, not carbs. So carbs might make you feel better momentarily, but salt will also do the same thing. Well, that's it's again, I'm pleased to be able to give you an update on cholesterol. It's going to be a wild ride, not because of any, scientific thing. It's going to be political and social and financial. And that Nick Norwitz is a rising star as a Harvard medical student. He's also Oxford trained PhD with his own personal transformation of fixing a disease that, really the medical world can't fix ulcerative colitis. What they do is they suppress the symptoms. Nobody really knows what causes ulcerative colitis and Crohn's, although my suspicion is that it's something related to carbohydrate, because when you stop carbohydrates, the symptoms and the disease can actually go away, like Nick's case. I don't know if you saw the very popular video of the fellow who had the ileostomy. I interviewed him, reacted to his video, where he basically, his bowel contents go into a bag, and he talks about how he never sees meat come out the other end, but he sees celery and carrots and all this vegetable matter. So we digest meat really well, but not the vegetable stuff. That was, if you haven't seen it, that was pretty fun to react to his video. Great. Well, until next time, thanks so much. Bye now. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.